template down here, and the person says not difficult at all, should then be followed by, a question. I notice that you are telling me that you have some pretty severe symptoms of distress, but yet you seem to be functioning well with that. Could you tell me a little bit more about that? Well, yeah, I've just gotten really used to it. I just cope with it. I get things done. I just don't feel good. And such a person like that, then you're really looking at chronic psychological problems or life problems, and they may be in therapy at that point. They may be seeing a psychiatrist for medication. They may be in between. They may have no interest in that, but at least now you understand that, and then can monitor. Is this affecting the treatment that you may be providing for the pain? And it may be that severe depression, even though it has no behavioral consequences for the person, is still an important contributor for the person's pain. So, the point here is that there is no really simple cookbook for how you put all of this together. It requires a lot of clinical decision making, it requires monitoring, and it requires continued interaction with patients around this complexity in order to begin to better understand and to unravel things that can be easily hidden, at the outset, because the patient doesn't even know what's going on. I've had patients who have had chronic anxiety and some pretty comprehensive behavioral consequences of that, who consider themselves completely normal, because that's what they have felt for 30 years. They don't know anything different. And only when they move out of anxiety can they then start to look at how anxious they were, how much that truly was affecting them. And the same thing for these other kinds of problems, such as depression and so on. The comprehensive screen, as on the right-hand column, includes all of the instruments in the DCT&D, and then there are other instruments that we describe in the book chapter for other domains. I'm going to go through these indicated in red just very, very quickly, just to touch on them. But as I said earlier, this is something that you would expect a specialist to be using, not yourself. I mean, a TMD or facial pain specialist, not a general dentist or a non-pain specialist. The first one is the functional limitation scale, which has items that assess the person's experience of how their body is functioning in the domains of chewing, mobility, and verbal and emotional expression. And, we published some very interesting data describing how other disorders such as Sjogren's syndrome, burning mouth syndrome, or orthognathic malocclusion will also report problems with this instrument. It's a very useful tool in a lot of areas of dentistry, but it's not one of the fundamental screeners. Second is overuse behaviors. And again, we've published a lot on the use of this instrument. What I want to highlight here is that the use of an instrument is a dramatically better way. An instrument like this is a dramatically better way of assessing for the presence of these behaviors than simply asking the person, are you aware of whether you clench or grind or do anything with your jaw during the daytime? That type of verbal interview tends to lead to a lot of false negatives. And the reason is because these behaviors are largely unconscious. People don't know that they're doing them. A self-report instrument like this prompts the person to engage in some type of personal introspection of, do I do this or not? Let me think about it. And then you get answers on here that are very, very different from what you would gain from an interview question. And patients will often say, wow, I had no idea how much and how many of these behaviors I do until I filled out this form. But again, it's not part of the ultra brief screen simply for the sake of trying to get at stuff the most efficiently that we can. But I think that this is a very, very useful screening tool. Depression, PHQ-9, is a longer version of the PHQ-4. This instrument also has a question regarding suicidal ideation. That is its one particular advantage. And then the GAD-7 is also a longer version of the PHQ-4 for the anxiety component, and both of these also have this magic box at the bottom that asks about impact. And then finally, there is the PHQ-15, which gets at comorbid disorders. And comorbidity in the area of chronic pain problems, comorbidity in the area of an acute pain being more likely than not to become a chronic pain, has become an increasingly major focus in the pain research world and recognized as, just like with the pain drawing, other disorders, whether pain related or not, have huge impacts on our pain processing system and what will happen with respect to the transition of any acute pain and the maintenance of any chronic pain going forward into the future. And so this is just one way of assessing that. There are lots of different tools. The PHQ-15 just happens to be a good one, but there are other tools that can be used. So then interpretation on this, there's a manual on the Inform website, and there is a scoring form posted there. I've shown part of that for you for some of the instruments. We've tried to make it as cookbook and as simple as possible. Once you have the reduction from numeric values into categories, because frankly, numbers just become a mix in our brains, and so we simplify it. We reduce it down to none, mild, moderate, or severe, for example, because at a clinical level, that's what we need. We need that kind of simplicity to go from numeric scores into categories. And once you have those categories, then the real challenge on decision making begins, because more often than not, it's not straightforward. And you have to decide, and this is where your interview becomes critical in terms of understanding which of those categories in the moderate or severe range, for example, are the ones that maybe you need to attend to, or maybe the ones that are not so important for this person. Here is a table of values for some of the variables that we've been talking about, such as pain intensity, or number of days that the person is disabled by pain, and comparing TMD, headache, and back pain. Because we typically don't think of jaw pain as having the same kind of severity as these other more prevalent disorders like headache and back pain. And yet, if you look at the values on this table, it's easy to see that TMD is just as severe in terms of the pain variables and in terms of the psychological or behavioral consequences as these other disorders. Unfortunately, your medical colleagues typically do not recognize this, and so this is something that we as in the dental profession have to be very, very assertive about in protecting and representing our patients well, who have TMDs and who have problems that are of equivalent severity to the other common pain problems of headache and back pain. Now, let me just show you a clinical study for the impact and meaningfulness of the things that I've been talking about. And this was a study done by Karen Raphael at New York University, and she looked at the effectiveness of oral splints in the treatment of myofascial pain in the face. And she used a traditional type of oral splint in the active treatment group, and she used a piece of plastic in the palate, piece of acrylic in the palate as the placebo control. And on the left-hand side, it just simply shows the two groups, the active treatment group and the palatal splint group, in terms of what happened with their pain from enrollment to just after treatment, 4 weeks later, and then 6 weeks later. And as you can see, the active group continued to show or showed some level of improvement, but so did the palatal splint group, such that at 6 weeks, the active treatment was only marginally more effective than the palatal group. If we look over on the right-hand side, however, and this is the cleverness of this particular study, She also assessed for whether the subjects in the study had widespread pain or not. And they were classified simply in that way, yes or no. And so now we have 4 lines. And then so there's the palatal splint in the local pain group. There's the palatal splint in the widespread pain. There's the active splint in the local pain. And there's the active splint in the widespread pain. And it is only the active splint in the local pain that shows clear improvement over time. And so, if you look at the results in any of the studies published regarding the use of oral appliances in the treatment of TMD, overall the results are largely a wash at this point in terms of, well, are they really effective or not? This particular study would suggest that, well, we need to think beyond just simply the local condition and think about other factors affecting the person's pain. And widespread pain is as good as any, as one of these kind of comorbid type conditions for using as in a research context. And this study, the results are just absolutely profound in demonstrating that if widespread pain is present, the active treatment is not as effective, and the placebo treatment is also rendered has the same efficacy as well. Let's see. So now we'll talk briefly about implementation. We talked earlier about you created a database, and then from that database, one of the ways to think about further reduction, further simplification, is to think about where does that person fit in some kind of a spectrum between severity on the axis 1 and the severity on the axis 2. And so, in this illustration, we created for the DCTMD to illustrate this. We created 2 hypothetical patients: one who has an obvious mechanical problem with the jaw, and who has pain that's very intense, but they have very little going on in the axis 2 domain. And so we believe that someone like this is going to be effectively treated by targeting the particular disorder. And in contrast, person B has no involvement of the joint, has less intense pain, but is much more affected by the pain in terms of pain-related disability, anxiety, and has high oral parafunction. And that this type of person is going to require a very different form of treatment than this person will. That's the fundamental concept. How you put all the data together in terms of assigning your patient to this kind of XY space, is not easy. And you can ask Dr. Gonzalez, you can ask Dr. Crow, and they will, to my mind, heartily agree that this is not easy work. It's a very, very complex decision making, and I have found that the only way to proceed forward in thinking about where does my patient sit in the space is that it's an ongoing process of assessment, of interview, of follow-up, of monitoring, and titrating. And with that, we will stop for right now. We'll take a 10-minute break, and then we'll come back with the second topic.
Thank you.
Alrighty, I'm going to stop my screen share.
We'll come back at 11:05.
Perfect. Thank you.
Welcome back.
Bye. Shall I begin?
Yes, please.
Okay, so in our second hour, I'm going to talk about one particular aspect that was addressed briefly before, and that is oral parafunction, what people do with the kinds of things that people do with their jaws. And this is a topic that is highly relevant for TMDs. It's also relevant for most aspects of dentistry as well, because the particular behaviors that we're going to describe here are not unique at all to people who have TMDs. So, as I've mentioned before, we created a self-report questionnaire for assessing these behaviors. And we did this about 20 years ago now. And it has been used in a lot of research around the world. It's impossible to summarize all of that here. But it has shown its value and a far better understanding now of how extensive these various kinds of behaviors of what people do, placing their tongue forcibly against the teeth, for example, or holding the jaw rigid. You can read the items here on the slide. And we don't have any cutoffs, at least at the moment, in terms of how you score this or how you interpret the score. There's different ways of scoring it. There's one way that I think is probably better, but it's still in development at the moment in terms of peer review. From a simple level, however, just simply identifying the presence of behaviors from your perspective as a clinician, and for the patient, even more importantly, to understand the extent and type of the behaviors is a huge step forward from having no awareness, no understanding at all about the presence of the behaviors, because they're typically unconscious. And more often than not, if you ask somebody, do you clench or grind your teeth during the daytime? No. Do you clench or grind your teeth during sleep? Well, I don't know, I'm asleep, are the typical types of responses. So I show on the bottom left someone playing with bubble gum and blowing bubbles. And the question is that a parafunctional behavior? Well, in one sense, yes. The jaw was not designed for that. Does that mean it's a problem behavior? Not at all. And it is that dimensional aspect of which behaviors and to what extent is that behavior done on a daily basis is what determines whether or not behaviors of this sort should be targeted for change or just simply ignored. And we don't know what the answer to that is at the moment, at least not firmly. We do have an inkling, however, which is that small amounts or low frequency of a small number of behaviors is clearly not a problem. High frequency of lots of behaviors is clearly a problem. And somewhere in between, then there is a cut point for when we shift from being appropriate to ignore the behaviors. The patient asks you, I clench my teeth sometimes. I've been monitoring. It happens a couple of times a week. I find myself clenching when I'm sitting at the red light and the traffic's moving slowly. Is that a problem, doc? And your answer may well be no, as long as you're not clenching too hard that you're going to break teeth. And of course, therein lies one of the complications. And so we created this image several decades ago based on the evidence that was available then. And we didn't know a lot about oral function at that time. But based on what was known 30 plus years ago, we created this image to illustrate the kinds of consequences that these behaviors can have. And I would say that in the 35 years since the evidence that we were aware of then, I don't know of anything that it changes the accuracy of this image. And so, as you can see, a lot of this is stuff that you're going to encounter as a dentist of whatever sort you may be outside of the TMD or facial pain field. And over the years, because I've become known for, various ways for this type of research into this particular area, and I've received letters from dentists over the years, and it's always highly rewarding of dentists saying typically the following thing. When I was in dental school and as a young dentist, I didn't really appreciate the behavioral aspects of dentistry. But as I've matured, I've come to see that these kinds of behaviors are extremely common and can be highly destructive. And I just wanted you to know that. And I'm always grateful to receive those kinds of letters because it was certainly my experience as well. As a young dentist, I was treating a patient who had a clicking and locking joint. I'd made a repositioning appliance to move the jaw, lower the mandible in a different location. It was what we did back then. And, she responded incredibly well for about 2 weeks, 3 weeks. And then the clicking and locking began to reappear. And, I checked the appliance and everything is all looking really good. And I'm like mystified because I'm doing all the so-called right things. Well, it turns out that this particular young patient had an extensive repertoire of oral parafunctional behaviors. And one of the things that she liked to do is to posture her mandible out and to one side. It was on the side where the clicking joint was in this particular instance, and then to hold it there and to press it forcibly, and then press the teeth her upper teeth and the lower appliance forcibly together in straining the joint. And my training at that point had not prepared me for understanding the role of behavior, because everything that I'd learned at that point was all about the structure. Let's fix the structure. And so once we started working with the behavioral changes, then everything then took off in the right direction with regard to the rest of the treatment. It was a very humbling learning experience. So here are some illustrations of what parafunction can look like at different stages in life. A 17-year-old up on the top who has some mild wear on the teeth, but very clear evidence of facetting over here in the cuspid area. And this is 17 years of age. And at the time that I took these slides, the general belief in the dental profession was that she did not have a stable occlusion, and that's why she was grinding her teeth here. And we now know that belief to be completely wrong. Here's a 40-year-old with protrusive bruxism, and you can see the perfect facetting and matching in the incisors. And then here is someone who, despite extensive prostheses, has continued to wear the teeth down as a 60-year-old. One of the reasons why we have this belief that parafunctional behaviors are caused by the occlusion come from two studies published back in the 1960s, both of them by Ramford. And I mentioned these studies to you in the freshman year in Dr. Soberai's occlusion course. They're worth revisiting here. The first study on the left, 32 patients who had pain in the muscles were recruited. All 32 had a sliding centric, and Ramford concluded that a discrepancy between CR and CO is the common trigger for all of that. And as I noted for you back then, you cannot make that conclusion from this study. This is a rancid, failed study because it has only one group in the study. It does not have the reference group against which one can compare these data. The second study, published looking now at electromyography and also a slide and centric, recruited 34 people with this disorder. And They're supposed to be, oh, I'm sorry. And, Ramford concluded similarly, such that in the 1983 textbook, you know, he set the stage for what dentistry should be doing. It appears that elimination of occlusal trigger areas are what dentists should focus on. In other words, we should focus only on the mouth and not outside the mouth. Well, these two publications have been extremely destructive for the dental profession. Papers published today that advocate a role of occlusion in the cause and treatment of TMD continue to cite these papers as though there's real evidence there, and there is no evidence. Contrast that with Posselt, a study in 1971 where he smartly recruited 36 people with and 36 people without TMD symptoms, and then discovers that, well, yeah, everybody has a slide. And I give you a p-value here in case you're interested, but I think that this simply the raw numbers inside the 2x2 matrix right here tell you the full story. So if occlusion is not the central problem here in parafunction, then how do we begin to think about how behavior and pain fit together? And one of the most common theories is the vicious cycle theory, which is that behavior leads to pain, pain leads to behavior, and so on. There's a lot of truth to that, but it's not as simple as that vicious cycle theory wanted to promote. The pain adaptation model, for example, demonstrates that at the spinal cord level, nociception, and I say pain here, but really it's nociception, leads to decreased behavior. And pain itself will also have an inhibitory influence on what happens at the spinal cord level, which would seem to refute the idea that behavior can lead to pain and pain can lead then into more behavior. The problem with this particular model is that it's a wonderful model in terms of what neuroscience can tell us about one aspect of how the nervous system functions, but it doesn't tell us what people actually do. Because if you're hungry, and if eating causes pain in the jaw, but if you're hungry, you're going to eat. And your behavior will continue. And yes, you will hurt after the meal, but hunger, motivation to do something will override the inhibitory influences in the nervous system. And in recognition of that, a number of different researchers around the world have created what is called an adaptive behavior models. And what they've discovered is that motor units will reorganize in problematic muscle tissue. And this has been studied extensively in the masseter muscle, that the motor units will reorganize in order to maintain the targeted behavior despite pain. And this has profound implications for the role of oral parafunctional behavior